Hello, everybody, and welcome to our TIF Talk Tuesday. I am so very excited about our special guests that we have tonight. You'll notice there's a lot more people on the screen. Again, my name is Andrea Millers with Endogastric Solutions. We're so excited to have you here today. We have some special guests all the way from Smyrna, Tennessee. I hope I said that right, Dr. Melvin and Dr. Taylor. But we have Dr. Willie Melvin and Dr. Josh Taylor here with us, as well as two of their patients. So before I go into introductions, I do want to first remind you this is live. So at any time, if you have any questions, please feel free to type it into the chat section, and we will do our best to answer any and all of your questions tonight. Also, I just commented in there and put in, please let us know where you're tuning in from, so we know where you're coming from tonight. So welcome, everybody, and thank you to all of our special guests for joining us tonight. Thank you. So before we start, I do want to give a little bit of background on our guest speakers tonight. We have Dr. Willie Melvin. He is a board-certified general surgeon at the Surgical Clinic of Rutherford in Smyrna, Tennessee. Dr. Melvin earned his medical degree from Meharry Medical College in Nashville and completed residencies at St. Joseph Hospital in Houston, Texas, and Vanderbilt University Medical Center in Nashville. He is a fellow of the American College of Surgeons and the American Society of Metabolic and Bariatric Surgeons, and holds memberships in the Society of Robotic Surgeons, Society of American Gastrointestinal and Endoscopic Surgeons, SAGES, and American Society of Veteran Administration Surgeons, and the Southeastern Surgical Congress. Welcome, Dr. Melvin. Thank you for being here tonight.
Thank you, Andrew, for having us.
You're welcome. We also have Dr. Joshua Taylor. He is a general surgeon specializing in advanced laparoscopic and robotic surgery at the Surgical Clinic Rutherford in Smyrna, Tennessee. He obtained his medical degree from Johns Hopkins University and completed his general surgery residency at Vanderbilt University. Dr. Taylor is board certified by the American Board of Surgery and is a fellow of the American College of Surgeons. Thank you so much for being here, Dr. Taylor, and welcome.
Thank you for having me.
Of course. So we have two other special guests, George Lang, who is one of Dr. Melvin's patients. If you want to wave and say hi, George, thank you for being here.
Yeah.
And then
you're welcome.
Thank you. And we also have Beta King here, who is Dr. Taylor's patient. So Beta, thank you for being here with us tonight.
Hello, thank you for having me.
Fantastic. So we're going to go ahead and start. And the first question I'm going to have maybe go towards Dr. Melvin. And Dr. Melvin, maybe explain to us, what is GERD, and what would patients that are suffering from GERD, what are the symptoms that they would have, or the issues that they would be suffering from?
GERD is G-E-R-D, gastrointestinal reflux disease. Some people refer to it as heartburn, indigestion. It has several different names. In short, it is an abnormal clearing of the normal reflex process. So we have, as normal every day, everyone has some degree of reflux. Generally, we have a normal valve mechanism which acts as a one-way valve, and we have things like our saliva and standing and swallowing that help to flush out that reflux. It becomes pathologic when that reflux happens too often, doesn't get cleared, or the valve mechanism is abnormal.
Yeah, thank you. And George, maybe you can explain a little bit, when did you first start having symptoms, and what kind of symptoms did you experience?
I had started having symptoms about 2 years ago, and it was pretty much feeling some pressure and acid reflux in the chest, getting heartburn. One of the things that I had also experienced was I had I felt like a metallic taste in my mouth, which is wasn't sure if that had something to do with GERD or not, but it was it was through that whole time. I was also having to take medicine to keep the heartburn and the gas and that down. So it just kept getting worse, and so went to see Dr. Melvin.
Okay. And the medication you were talking about, was it just the prescribed medication or just kind of over-the-counter medication that you were taking?
It was prescribed. It was Nexium, PPI.
Okay. And then did you get to a point where you just continued to take more and more helping with the symptoms that you were having?
It sort of made the symptoms less, but the symptoms never went away. They would just keep coming back. I tried to actually stop the medication a few times, and immediately I would get the same symptoms right back.
Yeah, is that pretty typical, Dr. Melvin? If people try to stop their medications, all of the symptoms just come straight back? What do you normally see?
Well, it depends. Sometimes there can be one event that causes a real severe episode of reflux, and then once you control that immediate or single event, then things can kind of go back to normal. For those people who do have an abnormal valve or an inability to clear, then as soon as they stop the medicine that's adjusting the acid, their symptoms can return. Or in George's case, they never really went away, they just slightly improved.
Right. Okay. Thank you. Dr. Taylor, can you tell us, what do you guys normally recommend patients to do when they're, to manage their GERD? There's the medical therapy, there's also lifestyle changes, food modifications. Can you talk through that a little bit?
Yeah, so certainly as specialists, we see patients oftentimes a little bit further along in their treatment algorithm, but for patients who initially present or have one of these episodes of GERD symptoms, then the first line of treatment would be lifestyle modifications. So identifying maybe what are possible triggers to cause them to have reflux symptoms. So whether that's dietary, so eating foods that are often acidic, so citrus-type foods, tomato-based products, those can trigger acid reflux symptoms. Coffee, so caffeine, caffeinated products, so coffee drinkers, soda drinkers can oftentimes have exacerbations in their acid reflux symptoms. And then certainly when you eat, so what time you eat can affect if you have reflux symptoms. Some people tend to have reflux symptoms at night, and so altering how soon they or when they eat before they go to bed, sitting or lying propped up at night, those are all things that can certainly help. If you're a smoker, smoking cessation is incredibly important. Weight loss and obtaining a healthy BMI is also very important. So lifestyle modification is very early in the process to help you control your symptoms. And then if it persists, so what Dr. Melvin was talking about in terms of having a one-time event and being able to come off those medications, if you try that, if you've done the lifestyle modifications and that is not effective for you and you're still experiencing reflux symptoms, then you are very likely going to need to, one of the options would be to be on medication more long-term or seek further evaluation for workup and other treatments.
Perfect. Thank you. And Beta, maybe you can tell us a little bit about your experience. What did you do to try and manage your symptoms initially?
I was on, I want to say 3 or 4 different medications. I was trying to watch, like what Dr. Taylor said, watch what I ate, when I ate, but it would get so bad. I mean, I would be sitting erect, in the bed sleeping, and I'd still have the acid reflux so bad that, as I told him, I was dreaming that I was drowning, and it was where it was coming back up.
Yeah.
And then this caused a persistent cough that I had for almost 3 years. And then finally I had enough and went to my regular doctor and said, I can't, it's enough. 3 years is long enough. Something has to be done.
Yeah, I was just going to ask you that. How long had you been suffering? And then maybe we can ask both of you. Beta, can you let everybody know that's watching, when did you actually have your TIF procedure?
December the 21st.
Okay, so recently. So you're still in the eating phase, not liquids anymore, but or are you eating normal foods now?
I am good to go.
Okay.
I'm still
nice.
watching my bread, so don't look at me that way.
Oh.
No sodas.
Oh, that's too funny. And George, what about you? When did you have your TIF procedure done?
November 18th.
Okay.
And so I'm pretty much through the diet phase and started eating regular again. I am watching, as Dr. Melvin had mentioned, watch what I eat and see how it impacts my stomach and that. And so try to stay away from the foods that bother my stomach.
Yeah, wonderful. Dr. Melvin, what can unmanaged GERD lead to if a patient continues to take their PPIs or just not do anything about their GERD symptoms? What could that lead to? Is there other implications that could happen? Get it treated?
Misery, Andrea.
Misery.
I
know.
So there are, as Beta mentioned, and as George alluded to, there are long-term consequences. And so certainly in Beta's case, she tried, one medication, she added a second medication. Despite dietary changes and lifestyle modifications, there were still, and in George's case, even taking the medicine, there was still not complete relief. And so you can have long-term sequelae of that acid refluxing back, and sometimes patients present to their ear, nose, and throat doctor with hoarseness, sinusitis, problem with their enamel on their teeth. So long-term reflux disease has several consequences. From an esophageal standpoint, the repeated insult of acid on the stomach, from the stomach to the esophagus, can change the lining of the esophagus. And that ultimately, unchecked, without evaluation, can lead to esophageal changes that can be precancerous and or cancer.
Yeah, can you talk a little bit about Barrett's esophagus? We have a lot of patients that have come on and watched our TIF Talks and either have Barrett's and or are afraid of Barrett's. And you kind of mentioned it a little bit, but do you want to talk more about that? Or?
So each lining of our intestine, depending on whether it's esophagus or stomach or intestine, the lining has a certain cell type. And the lining of the esophagus, the lower, where the esophagus meets the stomach, has a certain characteristic. And with repeated acid exposure, that cell type changes from a normal esophagus to become more glandular, and that is the Barrett's changes. And so that is precancerous. And so we know that if the acid exposure has been repeated and unchecked, that can progress toward precancerous cells.
Yeah, thank you. And then Dr. Taylor, maybe can you discuss the diagnostic pathway? What are the different tests that a patient that is suffering from GERD, what would they go through to determine if A, if they have GERD, and then B, if the TIF procedure would be a viable option for them?
Yeah, so there are several tests that patients will need to undergo to be evaluated for both workup of GERD and then to determine if they would be an appropriate candidate for the TIF procedure. The most common procedure that most patients are probably familiar with is what's called an EGD, or where we take a camera scope and run it down the throat and essentially just take pictures and take a look at what we see. We can certainly take samples. We can take biopsies to determine if something looks abnormal in the esophagus, as Dr. Melvin was talking about. Do they have those changes that are occurring in the lining of their esophagus? Do they have any signs of what's called a hiatal hernia, where part of the stomach is pushing up into the chest? Do they have any signs of ulcers in their stomach? Typically also do biopsies to evaluate for a type of infection that can cause people to have worse reflux, called H. pylori. And so that's one test that patients often undergo. And again, it's one of the more common that patients would be familiar with. And one of the earlier tests, especially when somebody's had long-standing GERD symptoms or some of these more severe symptoms where they're having, in Beta's case, she had a really severe cough. Those are symptoms, that sensation that stuff is coming up in the back of your throat. Those are what we would consider kind of more alarming type reflux symptoms. The next test would be if you don't see obvious signs of acid reflux on EGD, then you can do an actual test of the esophagus to see if acid is refluxing up into the esophagus. That's a pH test. What we perform is called a Bravo pH probe. So when we do the EGD, if we need to, we can place a probe into the esophagus that will measure how much acid is refluxing up over the course of several days. And that can give us an actual quantifiable number of how many times that's occurring, how severe the reflux is, things of that nature. Then the next set of tests would be to determine, as we were talking about, if they're an appropriate candidate for a TIF. And so certainly one of the things would be to know, do they have a hiatal hernia, which can be evaluated with the EGD. There's also X-ray tests that can be done. So what's commonly called a swallow test, where a patient drinks X-ray contrast and we look how it goes down. Does it go down appropriately? Is the anatomy normal? And then finally, we also want to know, how does the esophagus function? When we do the TIF or any type of reflux procedure, we're recreating a barrier. We want to make sure that their esophagus is going to be able to kind of move food past that barrier. So you just heard Beta talk about bread. Well, after the TIF right now, things are still kind of swollen and a little snug. And so bread's kind of soft, and it's a little bit harder for things to move down your esophagus when we've created that barrier. And so we want to make sure that long term, I fully expect that she's going to have no problems. She's in the healing phase still, but long term, I expect that she'll be able to go back to being normal because we did those tests in preparation for surgery.
Wonderful. Thank you. Before I continue, I do see quite a few questions popping up on Facebook. I'll pass it over to Wendy to start getting those questions asked.
Thanks, Andrea, and thanks everybody for joining us. I think we kind of overlooked the fact that today is a pretty significant day. It's, as Dr. Melvin just reminded me, Tuesday. Not only Tuesday of the week, but also 2/22/22. So, and then we have 2 doctors and 2 patients. Go figure. So thanks very much for being with us. The first question that we have is from Jason. And Dr. Melvin, I'll have you take this one if that's okay. He says, my wife is a teacher and her ENT says that her GERD is being caused by having to push her words out and talking loudly through a face mask all day. Her PPI drugs that he put her on aren't working. What would you suggest is the next step?
So anything that increases intra-abdominal pressure, and as Dr. Taylor alluded to, obesity, we oftentimes see it also with pregnancy. So anytime that there is increased pressure pushing up on the diaphragm, it can encourage some reflux. And in her case, having a mask, having to exert more pressure to force air through across the vocal cords and project out from the mask, that certainly can contribute to some reflux symptoms or exacerbation of her reflux symptoms. But also you have to understand that there's probably an underlying deficit. There's probably a valve mechanism that is not working well that makes her pressure and reflux not be able to be cleared adequately and therefore give her more symptoms. And in that case, I would recommend that she see either her gastroenterologist and or her primary doctor, and perhaps even over the counter give a trial of H2 blocker or a PPI just for a week or two to see if her symptoms improve. And if that doesn't help, then certainly consider a consultation for surgical solution.
Yeah, I would just add that, in the age of COVID, we're all certainly dealing with it. So the question would be, what's making it different for her? And so I think to Dr. Melvin's point, there's some likely underlying anatomical dysfunction, whether that's that her natural reflux barrier is lax, whether maybe she has a hiatal hernia that when she increases that pressure, that portion of her stomach gets pushed up, and that's allowing things to reflux. And so absolutely, I think that in addition to trying to generate more pressure, there may be something that is truly underlying that that's causing that.
Thank you so much. So, George, if you could talk to us a little bit about what, we often talk about patients and what they are experiencing. Can you maybe talk about what your friends and your loved ones were experiencing as you were suffering? Did people make comments? Did it affect your life? What were the things that you were able to do at one time and then not able to do as you started suffering?
Yeah, it's sort of depressed me because it was something that wasn't going away. It was always even with the medicine, I knew there was sometimes I still get heartburn and that, and working, I would get depressed, and my family could see it, and they would say we need to go see a doctor, and I fought it for 2 years, and till it got too bad, and I think part of that also was it was causing stress on me, and people could see that, and so it does affect the family. Definitely affects family.
Thank you. Beta, how about yourself?
Oh, do you know how hard it is to have a cough during COVID? Do you know how many times I said, don't worry, it's not COVID, it's just TB. So, but other than that, I know I drove my wife crazy, constantly coughing. It was from the time I woke up until the time I went to bed. I just constantly had that cough. And, doing anything, going anywhere, you're always coughing. And, I try to watch what I eat, when I ate, but it's still there. Even I think I was on 3 medicines and I was still having the acid reflux and stuff.
And
so yeah, it's not fun.
Did you cough when you were eating or drinking as well? Did you?
Oh yeah, it was always there. It's like little gargle on your shoulder.
Yeah. So did the TIF procedure give you your sense of humor, or was it there beforehand?
Oh, it just made it worse.
I love it. That's awesome.
Well, and so, Andrea, we've got a couple more questions coming in. They do cover, the TIF procedure and hiatal hernia and some questions about that. Should we maybe have one of the doctors talk about TIF and maybe the other talk about hiatal hernia? I'll let you.
Oh, go ahead. Who wants to take the TIF procedure? How does it work? What's the mechanism of action for that? And then if someone wants to talk about hiatal hernias.
So the transoral incisional application, or the TIF procedure, is a procedure that we do through the mouth, minimally invasive, that recreates the normal anatomic valve. And so, as we have alluded to throughout this process, and as Dr. Taylor has talked about, closing or providing a barrier, the normal barrier is a one-way valve that allows for essentially things that we swallow through the esophagus to go into the stomach and not come back into the esophagus. over time, increased pressure, coughing, sneezing, straining, sometimes that normal valve can flatten out. And now instead of a one-way valve, it's a two-way swinging door. And so the mechanism of trying to recreate that valve is unique to the TIF procedure in the sense that we can literally make a valve, and using these special, what we call H fasteners, we're able to secure and plicate a valve mechanism that allows to restore the physiology, the physiologic valve mechanism, which I think is unique to this procedure. And so by doing that, people are able to resume their activity, their reflux goes away, they're off medication, and their life is back, and their family appreciates it.
Yeah, yeah. And Dr. Taylor, what about the hiatal hernia portion of it? And maybe you can speak to each of the patients. Did they both have hiatal hernias that were repaired as well?
Yeah, so Beta came to me, and she had both a hiatal hernia and severe GERD. And so she had both an abnormal reflux barrier, but certainly the hiatus, we call it, is also part of the reflux barrier. So when we're talking about sort of what should be normally present, the swallowing tube, the esophagus should go through the diaphragm muscle and turn into the stomach within the abdomen. When you have a hiatal hernia, that opening within the diaphragm has enlarged, and the pressure from the abdomen is pushing things up into the chest. And so a hiatal hernia is oftentimes where most commonly the stomach gets pushed up into the chest. And so now you almost get sort of this hourglass configuration of the esophagus and stomach at the top with this more narrow waist. And so as things go into the stomach, it gets kind of stuck there. And so you're naturally starting to produce more acid to begin to break down that food. Things can't go through that smaller opening. At least for the stomach, it's a smaller opening. And so it puts more pressure back on that reflux valve and can cause things to reflux more. So when we're evaluating somebody who has reflux, we want to know, do they have that as well? Because we need to restore normal for both of those situations. And so that's exactly what Beta had. And she had something known as a C-TIF, or a combo TIF procedure, where we repaired her hiatal hernia surgically with several small incisions through her abdomen, and then through the endoscope performed the TIF procedure.
And so as Dr. Taylor suggests, there's the C for your viewers as they research it. There's the straight TIF and the C-TIF. I use the analogy of a threshold and a door, where the threshold is kind of the opening. And when we evaluate our patients, we want to look comprehensively to see if there's a defect in that hiatus that can contribute to their reflux, or is there a defect and an abnormal valve. And so when we address our patients for repair, we consider both. And in both of these patients, they receive a C-TIF.
Perfect. Thank you. Thank you. I do want to get to recovery. I'm curious to hear about Beta's and George's recovery from the TIF procedure, or C-TIF, if you will. But we got more questions that have popped up, so we'll try to get through some of those. Wendy, I'll let you ask those questions.
Perfect. Thank you. So we have one from Haley asking for both patients. Can you talk about your journey to finding your doctors who did TIF?
You want to go first, Beta?
It doesn't matter. I mean, I just, like I said, after 3 years of the cough, I went to my doctor and I said, I've had enough. And she referred me to Dr. Taylor. So, and he's absolutely amazing, even though he wouldn't let me wear my bow tie.
How about you, George?
Pretty much the same thing. Once I got tired of it, my family doctor found Dr. Melvin and referred me over, and that's probably one of the best things that ever happened.
So I do have a question. Met with the great physicians that are with us today. Did they walk through the different options, or was that given to you and presented? You know, there's other options, because right, Dr. Melvin and Dr. Taylor, there are other options for treatment of GERD. I guess the question I have is, what made you choose the TIF procedure? Maybe the doctors chose and said that that might be the right one for you, or did you guys look into it a little bit yourselves and kind of say, this is the right procedure for me? I'll let you go first, George.
Okay. Well, Dr. Melvin first wanted to make sure that it was something that I really needed, and he, after evaluating and hearing what was going on, he mentioned the Bravo test, and we went into that. He, I believe, he also did the took some samples from my esophagus and that to verify about precancer, cancer, and then once the results came back from all of that, then it was recommended after knowing that I had an issue with my valve and I had the hernia, that we went into the procedure.
Perfect. How about for you, Beta?
I actually had all that done prior to going to Dr. Taylor.
Okay.
So, mhm.
Okay, fantastic.
So,
And then what?
I guess-
Yeah, go ahead.
Thing I would say, Andrea, is certainly from my perspective, since beginning to perform the TIF, and it's one of the reasons I think that I wanted to do this TIF talk is because it has really changed certainly my approach and what I talk to patients and offer them. For patients that don't know, the sort of what we consider the gold standard would be something called a Nissen fundoplication, which is where we take and use the top part of the stomach to wrap around the esophagus. And unfortunately, we all have stories of patients who have had really unwanted outcomes from that in terms of inability to swallow, inability to burp or belch, and those things are incredibly long term. And so as I became educated on the TIF, first by seeing Dr. Melvin perform the TIF on patients, and then began to do it myself, it really has transitioned to a conversation of, I think this is superior. I've got patient experiences and patient data, and there's burgeoning data from the literature as well to support that. And so if I think a patient's appropriate for it, that's what I'm certainly going to offer. Oftentimes we'll talk at least about the fact that there are other options, but in terms of what, if I've worked the patient up or they've had the workup done and I think that they're appropriate for it, I think the TIF is the way to go. And so when we're, to answer the question about the patients in terms of searching things, again, one of the reasons that we're doing this today is we want patients to be able to know what is out there, know what exists. We certainly have patients who come to us because they're referred to us from other doctors who may not even necessarily know what it is that we do. And so we want to use this as an opportunity to educate folks, to kind of put the power in their hands to say, maybe there's a better mousetrap, a better way to do this.
Love that.
Talk about, Andrea, how the patients come to find us. Part of our campaign, as Josh has mentioned, is to certainly do things like this to get that information out there. Along with that, we'll go to our referring physicians and have them understand what the options are and what our outcomes are. And so their physicians, their primary doctors, understand what we can offer. And more patients are looking for alternatives to long-term PPI. And this is one of those solutions.
Yeah, no, that's fantastic. And to your point, I'm looking at all the comments coming through, and there's 2 patients that are asking if you take new patients. So yes. There you go. But there you go.
That's a short answer. Yes.
There you go. I know Wendy's got a couple more questions that she wanted to try and get through. So go ahead, Wendy.
Yes, so we have Warren, who is concerned about later on in life. He's been on PPIs for a minute, we'll say, and he says he has a hiatal hernia. Every evening I'm eating, I get bloating and gas, plus I have to belch a lot. If I couldn't belch or burp to relieve the stomach pain, it would be so devastating. So I fear if I get the TIF procedure, he kind of says ... He's trailing off. He said, why is it that I belch so much every evening?
So it's interesting. One of the gold standards prior to the TIF, and we're transitioning, is what's called the Nissen fundoplication, as Dr. Taylor mentioned. One of the consequences of that procedure is wrapping that top part of the stomach around the esophagus in an external manner to try to recreate the valve. One of the consequences is not being able to burp or to throw up, and what we call gas bloat. And so as you're having your reflux, unbeknownst to you, you are actually swallowing air. And that increased swallowing of air blows up your stomach like a balloon. And then the only thing you can do to relieve is to belch. And so the hiatal hernia is part of that process where it's things going in and building up and only being relieved by belching. In your case, like most of the patients we evaluate, it's a question of determining if you're a candidate for repairing the hiatal hernia and recreating your valve with the TIF procedure. The advantage of the TIF compared to the Nissen is that you can burp after the procedure. You don't have that as a consequence. We talk in terms of wrapping the stomach, and so the Nissen is what's called a 360-degree wrap, where it wraps all the way around, which is why sometimes if it's too tight, people have trouble burping or belching, whereas the TIF is really a 270-degree. So it's kind of a partial wrap, but it's more physiologic and really accentuates and recreates that valve mechanism that acts as a one-way process, one-way valve.
Wendy, do you got more questions?
I wanted to ask Beta for George. Do you all agree with that? Do you find that you are able to burp or belch fairly easily?
Actually, quite better.
Yes. much easier to burp, and it also, now when I burp, I don't get that gas, the heartburn, and so it's much better. I told Dr. Melvin I feel a whole lot better after that. So it's been good.
Good, thank you. So Dr. Taylor, could you talk about I've got two questions about testing. One question is, what is the best test for LPR? The second is, I've heard manometry is awful. Do I have to have it? Can you talk a little bit about that?
So I'll answer the second one first. I base the decision off of for manometry very selectively at this point. And so Beta, unfortunately, I did force to go through manometry, but I don't do that for everyone at this point. We have access to a different type of esophageal evaluation called EndoFlip, which we oftentimes couple when we do EGD. And so if patients have any concerning abnormalities on that, then I will typically follow it up with manometry. So for those that don't know, manometry is essentially a measuring of the way that the esophagus functions, the pressure and the way it's generating a wave. It should be almost sort of, snake-like in terms of the way it moves things along down the esophagus. And we want to make sure that that's normal for people who've had longstanding issues with GERD and hiatal hernias. Potentially that esophagus is, for lack of a better way to describe it, kind of gotten burned out. It doesn't want to work the way that it should. And so if you then end up creating a barrier that is too much for it, then you're going to have problems swallowing it. So we want to know that to know exactly what the appropriate procedure is to offer you. And so I do manometry selectively at this point. I forgot the second question. I apologize. Or the other question. I apologize.
It was, sorry, LPR. You know, what's the best test for LPR?
You're going to have to define LPR for me.
Laryngeo-pharyngeal reflux, the silent reflux.
Gotcha. So folks that have laryngeo-pharyngeal reflux are oftentimes evaluated by ENT, and so they're going to do a direct laryngoscopy oftentimes in the office, and they'll see signs of reflux in the back of the throat. As Dr. Melvin alluded to, they may have enamel breakdown, and so they may have, essentially issues with cavities more frequently in adulthood that has popped up for unclear reasons. And so oftentimes that's something that a ear, nose, and throat physician will evaluate when they see folks who are having reflux problems.
Perfect. And Wendy, did you see there's a couple more questions that just popped up?
Yes, I do. So number one, I've had 4 endoscopies and still have swallowing issues. I've been told that the scope used in the TIF procedure is a bit bigger. Does your esophagus have to be measured before having the TIF procedure? Can you talk a little bit about that? And then also, if you don't have a hernia but have inflammation in the stomach and you're constantly burping all day, no meds are working, would I be a good candidate for this procedure?
So I'll take the first one, and the scope is usually a smaller scope because it fits through the actual instrument. And yes, as part of our evaluation for the procedure, we do what's called a bougie. We put a device down that kind of measures and stretches if needed to make sure that the scope, which is placed inside of the instrument, can actually fit into the stomach without any difficulty. And with rare exception, most people can tolerate the TIF device without any problems.
Perfect. And the second part, Wendy, is this person, Catherine, is saying that she doesn't have a hernia, but does have inflammation of the stomach and constantly burping all day, that no meds are working. Would she be a good candidate for this procedure as none of the medication is working?
So in her case, the burning and the irritation may well be from H. Helicobacter pylori infection. I think she would need a biopsy and an endoscopy. If she doesn't have a hiatal hernia that's demonstrated on endoscopy, then certainly she might be a candidate for a straight TIF, where there's just the recreating the valve without the need for repairing the threshold or repairing the opening in the diaphragm that the esophagus normally comes through.
Okay, thank you. And then I think we'll just get that last question in, Wendy, and we'll continue.
Yeah, and I'm sorry, I'm having a couple of technical issues here, so I will turn it over to you. But we have 2. Number 1, Julio is saying, I have pulmonary fibrosis and GERD. This condition makes my breathing hard and it's painful. Is this something that you would see me for as far as treatment goes?
Yeah, I mean, I would certainly say that anti-reflux procedures have been shown to be incredibly beneficial in patients who have underlying pulmonary disease, because reflux can worsen that. Certainly very familiar with seeing patients in my training who were transplant candidates who had reflux disease. And so that reflux can be incredibly damaging to the lungs. And so absolutely, I think that very much would be a reason to consider having a TIF procedure.
Very good. Okay. Last but not least, William is asking if a failed TIF could lead to diverticulitis of the esophagus or other odd issues. For instance, if the TIF is too tight and then the whole TIF becomes a new hiatal hernia, can that make things much worse? Any thoughts there?
There are a lot of things going on in that question. So, the anti-procedures we mentioned, the C-TIF has both repair of the hiatal hernia and the anti-reflux portion with the TIF. And yes, the repair of the diaphragm can sometimes fail, and you can have a recurrence or a reherniation of the portion of the stomach that has the TIF in it into the chest. And so the initial management is going to be to try to repair or re-repair that hiatal hernia to get things back where they belong. It's not unique to the TIF, but any procedure that tightens that GE junction, tightens the junction between the esophagus and the stomach, can increase pressure. Part of our evaluation is to determine if there's normal esophageal function prior to, as well as measuring the hiatus at the time of the surgery to make sure that we've closed it appropriately, as well as the wrap of a TIF is a 270 degree, not a 360 degree. So the likelihood of that being so tight that it causes esophageal abnormalities and consequently a stretching of or a diverticulization, it's pretty low. So there's a lot going on in that question, but to try to break it down, there are solutions, and it's a matter of kind of parsing it out and fixing them one at a time.
Perfectly said. Thank you, Dr. Melvin. I kind of want to get to Ben and George before we we're almost at the top of the hour. There's so many good questions, and thank you for asking them. But Beta, tell us a little bit about your recovery. And I know you're, what, 2.5, 3 months out. How are you feeling? And what's the one thing that maybe you want to tell other patients that are watching this, that why you would get the TIF procedure or why you would recommend it to them?
Because it's been a godsend. I mean, it's changed, pretty much everything. Like I said, I don't have the cough anymore. I don't have those dreams that I'm drowning and it's coming back up in my throat. I'm not, it's just everything's changed. I wouldn't wait. If you feel like you have any of the symptoms that George and I have talked about, I absolutely would not wait. I would go ahead and get it done. So it was worth it,
That's
every
great.
minute of it. Even the garden hose that went up my nose was worth every bit of it.
Oh my goodness. And thank you for that, Beta. And for George, what about you? How has it been for you, couple months out having the TIF procedure? How do you feel today? What would you recommend to other patients that are suffering?
Well, I have to say, compared to Beta, my suffering probably wasn't as bad. But I'd have to say, even if it's, if it's affecting you in any way, it's something to have done, because, like I said, for me, it was, there was pain, but, once I had the surgery done, it was great when when we got through it, and I even made it through the diet, and so that
You're both still alive.
Yes. Hey, I lost 20 pounds.
Both Beta and George, if you take a moment and kind of share with the listening audience what that means. We have a program and we try to graduate and explain in detail, but if you'd be kind enough to share kind of what that diet was like after the TIF procedure and how important it was.
Well,
it was.
Go ahead.
Sorry. It was the diet, and I understand it was to help the healing process, and you start out on liquids for a couple of weeks, and which is good, and then you start bringing back solid foods, which also help me, at least for me, it helped me to find out what foods, which I never worried about before. I'd eat anything, whether it hurt me or not. And now I've learned, to do that. It also helped for my meals, where I'm not eating so much at one time. carry that on even after we went through that 7 weeks. I've carried that on because it's not just the surgery, but that also has helped me to feel better. And so it was pretty good.
Thank you. Thank you.
Yeah. And like George said, I have done that as well. I catch myself still whenever I'm chewing, I'm counting 1, 2, 3, 4, how many times, and I try to eat slower. So, yeah. And the best thing is that, which my wife just, reminded me, that I'm not on any medications for anything anymore, for the indigestion or anything. And that's awesome. Especially as I was taking like 4 a day, I think is what it was.
Wow. Wow, that's fantastic. How about you, George? Are you off all of your not all, but the medications for your GERD?
Yes. Yeah. I don't take any medications at all, even over the counter.
Wow.
I haven't had to touch anything.
Fantastic. Well, thank you for sharing your stories with us. Before we conclude, though, Dr. Melvin and Dr. Taylor, as I had mentioned, there's quite a few people that are on watching tonight, and I've asked if you take new patients. Can you tell the audience that are watching how they can get a hold of you? How do they make an appointment? Talk maybe a little bit about your practice and give them your information if you don't mind.
So I believe Christian has the contact information on the link. Our number is 615-223-9935. It's a matter of calling and giving us a diagnosis and letting our office staff know that you're interested in being evaluated.
And I would just say that, we work to see patients kind of wherever they are in kind of the workup phase. So even if you've maybe just been taking over the counter medications and not gone through that, we will see you and evaluate you, and we can do the workup phase as part of that. So you don't have to come, kind of fully packaged, if you will. We're very willing to see you at whatever stage of the ball game and kind of start that process with you.
That's a good point. Yeah.
It's really just about having a conversation. All of you out there that are listening that may have doubts about having surgery, if you're having symptoms, you're watching this. If you're watching this, it warrants a conversation and make an appointment. Come talk with us. Sit down. We'll go over things. We'll review our options and determine whether this is something that will benefit you.
Perfect. Well, if you are watching and you are in the Smyrna, Tennessee area, or maybe even not, I don't know if you guys see patients outside of your market, but again, their contact information is on the screen, so you can grab it from there, or you can visit our website called gerdhelp.com. There is a physician finder on there, and you can put in your zip code or your state, and you'll be a TIF trained physician near you. Well, I can't thank everybody enough for being on here. I know this was an hour because we had so many people asking so many questions. So thank you for being engaged and watching. And to you, Dr. Taylor and Dr. Melvin, thank you for your expertise. And Beta and George, thank you so much for your stories. I know everyone watching really appreciates it, as we do too. So thank you, everyone. Please stay safe out there and have a great evening.
Thank you. Thank you for the opportunity.
You're welcome.